My name is Manahil Malaika, and I am a second-year medical student from Shalamar Medical and Dental College. And with me, I have
I'm Mohammad Suhaib Mubashir from Shalimar Medical College, and I'm also a second year MBBS student. So, the second session is about to start. I'll ask everyone to please have a seat. Please take your seats. The second session is about to commence. Thank you. Everyone, please settle down. We're starting in a minute.
Before we proceed, I ask the audience to kindly switch off your mobile phones to avoid any sort of disturbances. And please also note that you may write any questions that you have on the question cards that have been handed over to you, and we will open the floor for questions at the end of this session.
The second session of this conference will discuss vasculitis, and the session will be dedicated to Dr. Khurram Manzoor Chaudhary, who served as the second president of Pakistan Society of Rheumatology from 1998 to 2001.
Let us now introduce our honorable chairs for session 2. We have Professor Dr. Bilkis Shabir, who is a professor of medicine and director of QEC at Fatma Jinnah Medical University, Lahore. Dr. Saliha Ishaq, who is a consultant rheumatologist at Aga Khan Medical University Hospital, Karachi. May I please request her to come on the stage? Thank you. And Professor Dr. Abid Bhatt, who is a professor of medicine at Shalamar Medical and Dental College, Lahore. Thank you, sir. Professor Dr. Syed Nayab Haider, who is a professor of medicine at Central Park Medical College, Lahore.
The first speaker of this session is Dr. Beena Hamid, who is a consultant rheumatologist and internist at the King's College Hospital in Dublin. I'd like to invite Dr. Hamid onto the stage to speak on Behçet's the hidden disease.
Right. Good morning or good afternoon, everyone, and assalamu alaikum. And thank you very much for the organizers of Pakistan Society of Rheumatology for inviting me at the Silver Jubilee. Thank you very much. So I've been given the task to speak on Behçet's disease or disease of silk root. I have no disclosure about this talk. So I'm going to speak in the next few moments about the prevalence and pathogenesis of Behçet's disease, manifestations to diagnosis, and lastly about the treatment and the updated, 2018 updated guidelines by EULA. So the first glimpses of Behçet's disease you can find as old as 5th century BC in a Hippocratic third book of Endemic. And the first triple symptom complex was published by Hulusi Behçet, who was the Turkish dermatologist. He described 3 cases where patients have orogenital ulcers and hypopyon uveitis, and thereafter many other manifestations were added to the disease manifestations. And the name was given firstly in 1947 in a conference as a morbus patchitis by Professor Mishner. The prevalence and the distribution of the condition varies from different parts of the world, but you see the highest prevalence in Turkey, where you see 80 to 370 cases per 100,000. Then it follows the Japan, Korea, China, Iran, Iraq, Saudi Arabia as 13.5 to 35 per 100,000. And then you see in North America and European countries, the least, like 1 per 15,000 to 1 per 500,000 has been described in different series. The usual onset is around 20s, and it's rare before puberty or after age 50 years. And the disease affects equally men and women, but somehow it's more severe in men and at the early, younger age. The pathogenesis of patchitis disease is rather complex. There's various genes have been described, but more commonly it's been associated with HLA-B51. And it's been described that the severe people who have the positive gene, they suffer from severe disease. So initial event is in the presence of genes, there is trigger of the innate immunity, and innate immune system, then there's a production of various cytokines, and these cytokines produce the different inflammatory lesions in disease manifestations. But if you see on the other hand, it's not only limited to innate immunity, but also adaptive immune system. That's the reasons there is different concepts put forward. It's autoinflammatory or autoimmune disease, but perhaps the both. And you see there are different cytokines produced once immune system is triggered, either it's innate or adaptive immune system. But these cytokines, they share the different pathway, but there's some similarities. For instance, if you see the TNF-alpha, you see in both innate immune arm and as well as the adaptive immune arm. And then other cytokines like interferon, you see in innate, and the Th1 cell arm of the adaptive immune system. Similarly, IL-21 has the pathway involved in both. And these cytokines, they have different effect on the human body, and the disease manifestation you see depends on what cytokines been active in that particular individuals. Hence, the treatment is very different, and that's the reason why people get so heterogeneous disease manifestation in a population. So, clinical manifestations point of view, oral ulcers is the most common feature that we come across. Almost all the people, they are affected. And the ulcers could be minor or major depending on their size. And the cutoff is like 1 centimeters. The minor ulcers, they heal quickly, and because they are not deep enough, and usually within 1 to 3 weeks, and they do not usually scar. Whereas the major ulcers, they can be very painful because the tissues are deeply affected, and they usually take longer to heal, and they can scar as well. Typically, they appear as rounded, well-defined borders, and they have a whitish to yellowish necrotic base and surrounding erythema. However, we also know that the mouth ulcers are not uncommon. We see in a lot of other conditions mouth ulcers. So one has to be open-minded when it comes to diagnosing people with just one manifestation. You have to think about common infections to HIV. You have to think about some nutritional deficiencies. You have to think about the connective tissue diseases, and certainly people who are under a lot of stress, and certain diets can also induce mouth ulcers. The genital ulcers are seen in about 3/4 of patients, and in men, testicular and the women vulval area is the most predominant place. And they usually appear as a pustules or papule, which quickly ulcerates into an ulcer. It usually is aseptic. However, it can get a secondary infection. And usually they heal within 3 weeks as well. They frequently scar as opposed to mouth ulcers, and they might be associated with epididymitis, salpingitis, and a varicocele formation as well. The cutaneous manifestations can vary, but the commonest that you see in the skin is the pustular lesion in about 85% of people. They look like acne vulgaris lesions. The nodular lesions are seen in about 60%. Half of them would be erythema nodosum-like ulcers, and half of them would be superficial phlebitis. The pyoderma gangrenosum is quite rare. But the important aspect of the disease is that most of the people have pathargy reaction, which is actually a non-specific hyperreactivity reaction to even a minor trauma, leading to formation of erythematous papular pustules. There is also a description of vascular pathargy, which essentially means when you perform a procedure pricking the vessel, it can lead on to formation of an aneurysm of phlebitis. The eye involvement is seen in different series as low as 1/4 to 3/4 of patients, but this is very important because it usually is posterior or panuveitis, which is sight-threatening. If it's not treated in time, it can lead to irreversible visual impairment, even blindness. And in majority of the patient is bilateral. And you see it more in the earlier course of the disease. Intestinal rashes has been reported as 3 up to 60% of the cases. The patients might have a very mild symptom, such as just abdominal pain, but they might present with a severe complications such as perforation or massive hemorrhage. And it usually is a poor predictor of the response to treatment, and the prognosis is not favorable if patients present with intestinal disease. And the problem is it mimics to inflammatory bowel disease, in particular Crohn's disease, but there are certain things, if you look into, you might be able to guess what it could be instead. So first of all, you have to look at the endemic area. If it is along the Silk Route, you think of more in terms of Weissen's disease, whereas if the person is from Europe, America, or United Kingdom, you think of more inflammatory bowel disease. I just said that the uveitis is more posterior panuveitis in Weissen's disease, whereas in inflammatory bowel disease, we see mostly the interior uveitis. And there are certain other features, such as thrombotic events are more common in Weissen's disease. You see it in more arterial and venous type of all the vessels. It's already 5 minutes, so okay, fine, I have to rush then. In Crohn's disease, you might come across some antibodies, whereas you won't see that. Histopathologically, it's a vasculitis. Weissen's is vasculitis. Crohn's is granulomatous inflammation. And people have also described the endoscopic appearance of the ulcers. If they are rounded, you think of more of Weissen's. If they are longitudinal, think of inflammatory bowel disease. And if it is irregularly geographic, then you look at the distribution. If it is focal, then you think of Weissen's, whereas if it's segmental diffuse, you think of Crohn's disease or inflammatory bowel diseases. The CNS manifestations are rare, but then most of the cases is parenchymal, which carries a poor prognosis, and the dural sinus thrombosis is seen in 1/5 of cases, but they do have a good prognosis. The vascular breccias can be difficult sometimes to treat. The peculiarity of the Weissen's vascular involvement is that it can find any vessel size, both the arterial and the venous part of vasculature. And you see venous thrombosis in the different part of vasculature. I won't go into details because of the time. I've just been given a 5 minutes alert. So you have arterial involvement, in particularly the problem with the arterial side of the vasculature is they often tend to have aneurysm and bleeding for them. And when arterial thrombus, you see, normally you tend to anticoagulate, but then you might have a difficulty deciding unless you are sure that there's no vessel wall damage to cause further bleeding from anticoagulation. The arthritis usually affects the larger joints, and it's intermittent and lasting for 1 to 3 weeks, and it's non-erosive. The less common manifestations include renal and cardiac. So because the disease is so heterogeneous, so obviously like any other conditions, you look for the criteria. So the latest criteria is the international criteria published in 2010, and which gives you a higher score if patients who have oral or genital ulcers and eye lesions, 2 each, and the skin, vascular, CNS, and pathargy test gives you 1 each. So anybody who has more than 4 scoring, the sensitivity is 94% and the specificity is 90.5%. But again, these are classification criteria rather than diagnostic criteria. Pathargy test is very easy to perform. You use just 20 gauge needle. You prick at the skin at 45 angle with a depth of 3 to 5 millimeters, wait for 48 hours, and you'll see a sterile pustules. Sensitivity is 65%, however, specificity is not great, because obviously you can see it in other conditions as I listed there. And then also it depends what population you're studying. In Turkish and Mediterranean and Japanese population is seen more frequently, whereas in European, United States, you don't see that frequent. So the treatment is quite challenging due to the fact that the etiology and pathogenesis of the disease is uncertain, and the manifestation is so heterogeneous. It's a rare condition, and there are few laboratory markers which help you for the disease. So glucocorticoids are the mainstay of the treatment. The other treatments are used depending on what organ system's been affected. I'm just going to quickly run through. So here are the commonly used treatments. But if you see all these off-label treatment, most of them they work on the orogenital ulcers or cutaneous manifestations, but they're not useful in the more serious disease. So apremilast, which is the phosphodiesterase 4 inhibitor, has been approved in 2019 by FDA, and this is just a quick study where they saw that the drug works as quick as within a week, and then there's further improvement in the symptoms, and up to 12 weeks they studied it was quite effective. But again, in the mucocutaneous more than the serious condition, the manifestations. So anti-TNF, etanercept has been used in refractory mucocutaneous lesions, but not in other organ systems involved. And monoclonal antibodies you see in refractory uveitis, venous thrombosis, arterial thrombosis, intestinal and neurobasis, and refractory arthritis. Other TNF people are just trying, but there isn't enough data to comment on. Non-TNF, ustekinumab and secukinumab has been used. Again, mostly it's been found to be effective in refractory oral ulcers or cutaneous disease. So EULAR updated its guidelines in 2018, and certainly the goal of treatment is to suppress the inflammatory process and exacerbations or recurrences so as to prevent the organ damage. And certainly you need a multidisciplinary approach depending on what organ system is affected. If somebody's got severe uveitis, you would like to ask your ophthalmology colleague to help you. Somebody's pulmonary lesions, you ask for pulmonologist, and etc. So for mucocutaneous lesions, you typically for topical measures like corticosteroid, or for orogenital ulcers, or if it's not effective, you might go for more advanced treatments. But colchicine is found to be effective in erythema nodosum. Leg ulcers might have a venous stasis or a proliferative vasculitis. You have to decide, first of all, what is what. So you just certainly need a vascular colleague and also the dermatologist to help you, and then give them treatment. Arthritis, colchicine, if not effective, you go for more advanced treatment like TNF-alpha, intra-articular glucocorticoids if it's a monoarticular disease. Inflammatory eye disease, as I said, is mostly posterior segment involved, so you have to treat it more aggressively. So you give them azathioprine, cyclosporin A, or monoclonal antibody, TNF, and of course systemic steroids, as I said, is the mainstay initially. So of all the monoclonal antibodies, the infliximab has been studied more, there are more cases and case series published with. And certainly severe eye disease, such as like a drop of more than 2 lines in visual acuity on 10 to 10 scale, or there's a retinal disease, certainly you go straight away with anti-TNF, it's with high-dose steroids. Gastrointestinal disease, again, you start with the standard disease-modifying therapies, and if not, then you just go for anti-TNF. And surgical consultation only when there is complications such as major bleed, obstruction, or perforation is noted. Neurobasis, you treat with high-dose corticosteroid, following with very slow tapering, and then you give them azathioprine, monoclonal antibodies, depending on how bad the disease is, certainly. And the anticoagulation, again, is important to make sure that there isn't any aneurysm. Particularly, you have to have maybe a CT chest to look for any aneurysms, because they can bleed if you give them anticoagulation. And also the fact that the lesions are usually inflammatory. They're not thrombotic lesions like other thrombosis. So you have to control the inflammation to prevent or limit the thrombotic event. So vascular disease, again, you use glucocorticoids because, as said, it is inflammatory lesion. And you suppress with immunologic, suppressant like azathioprine, cyclophosphamide, or cyclosporine A. And in refractory cases, monoclonal antibodies. Arterial thrombosis, in particularly pulmonary thrombosis, can be very severe, and you have to act quite quick. You have to make sure there's no underlying aneurysm, cyclophosphamide, corticosteroids again, and again, for aortic and peripheral artery aneurysm, the medical treatment remains the same, cyclophosphamide, high-dose corticosteroids. And certainly when there is a complication like stenosis in aneurysm, you might need the help of a vascular surgeon. So in terms of prognosis, in this cohort, you see about 9.8% of the patients died of major vessel and neurological disease. But it's generally seen that the mortality and the morbidity decreases with time, and disease burden lessens as the time goes on, and the major vessel disease and neurological involvement might occur later in disease as well, where you might think, well, the disease is very well controlled, you're safe. But you have to monitor these patients very carefully. So yes, in conclusion, there are distinctive features of Pasha's disease which help you to gain the confidence in diagnosis. And there are various factors you have to keep in mind when you're deciding what would be the best treatment for these patients. And yes, about 2/3 of patients actually, if treated well in time, they reach the remission status. And thank you very much. I just stop it here.